Good afternoon, everybody. We are just going to let the room calm down a little while people come in, and then we shall start in a few moments, if that's okay. Always great to see people's faces. If you want to put your cameras on, that's great. If not, fully understand. And I think we will get started while people are just coming in. So good afternoon, my name is Richard Earzz, and I'm a social care advisor at Care England. And I want to welcome you today to our webinar, Redefining Overnight Care, Closing the Safety Vacuum and Reducing Bedroom Falls with Acoustic AI Monitoring. So as you all know, falls remain one of the most persistent risks in a care setting, particularly overnight when residents are in their rooms and staff can't be everywhere at once. Traditional call systems remain very important, but they depend on the person being able to recognise that they need help and then physically to be able to call for it. So for people living with dementia, reduced mobility, communication difficulties or changing needs, that's not always going to happen. So we're therefore reaching a point where some form of proportionate in-room support beyond the traditional nurse call systems feel increasingly inevitable. So, that does not mean that we're replacing staff. It doesn't mean we've got intrusive surveillance or allowing technology to make any of our care decisions. It means giving care teams better information about what may be happening between those physical observations so they can respond when support is genuinely needed, rather than relying on scheduled checks or waiting till after an incident has actually occurred to deal with the occurrence. Used well, these types of technology have the potential to support prevention rather than simply record harm after the event. It can help staff to protect sleep, which we know is incredibly important, avoid unnecessary disturbance, respond more quickly to changes and provide care that is more personal to the individual. And that's as much about dignity as it is about safety. People should be able to rest without repeated interruptions, while still having the confidence the support is available when they actually need it. So today's session will look at acoustic monitoring in practice. We're going to hear at a high level how the technology works, what providers have learned from introducing it, importantly, and the evidence they've gathered around falls, overnight care, and the importance of staff engagement and change management as a principle. We'll also consider how alerts and patterns can improve additional information within care teams while keeping professional judgment and human decision making at the very centre. So this is really intended to be a practical and honest provider discussion. We're going to hear both about the benefits and about some of the challenges of implementing this type of technology, which includes staff confidence, alert settings, training, and embedding different ways of working. And before we kick off, a few housekeeping points before we begin. The session is being recorded, and the recording and the slides will be shared with all registered attendees after the webinar. So please put any questions into the chat as we go, and Prad will pick these up at the end of the session. We have around 15 minutes for questions and answers at the end. I'm incredibly pleased to be joined today by Prad from Earzz, Raj from Armscare, and Karen from the Hub, who'll share both the technology and their direct provider experiences now. So I will come back in at the end to thank everyone and close the event. So without further ado, please let me hand over to Prad to begin the session. Prad, over to you.
Thank you so much, Richard. Can you see my screen pop up?
Yes, we can. Perfect.
Very good. Excellent. All right. Well, thank you so much again, Richard, and welcome everybody. I'm thrilled to be joined today by two fantastic sector leaders who have truly embedded the non-intrusive acoustic AI that Richard was talking about within their own care setting. So Raj Sehgal, who is the CEO and director of Armscare, and Karen Johnson, who heads clinical services and leads the team at Heathlands Village. Over the next 45 minutes or so, we'll be looking at audited multi-month impact data, presenting real-world clinical outcomes, operational efficiency gains, and also talk a little about the practical change management takeaways. With that, let's jump right into it. Can you see my second slide show up, everybody? Yeah. Very good. Okay. To give you some context for today's discussion, the data and insights we are sharing aren't from a brief trial in a handful of rooms. We are looking at longitudinal trends tracked across multiple months in diverse care settings. On one end of the spectrum, we have Heathlands Village, a large complex with over 100 beds, where managing clinical night triage across widespread wings requires pretty high efficiency. And on the other hand, we've got Armscare Group operating community-scale homes ranging from 20 beds up to 50 beds. And we'll be looking at data from 3 of their portfolio homes, Terrington Lodge, Docking House, and Driftwood House, where personalized dementia care is paramount. Across both scales, non-intrusive AI has helped demonstrate clear gains in both resident well-being and workforce benefits, and we are here to explore those together today. Let me jump in, right? Can you see my third slide pop up? Yeah, perfect. Okay, so that's moving as needed. That's great. Okay, before we jump into the clinical impact data, I think it's worth spending a bit of time unpacking the hidden care gap. Overnight care often comes down to one key goal, which is keeping the residents safe while letting them enjoy a peaceful night's sleep. Historically, as you may all well know, care homes have relied on periodic scheduled room checks, usually once every hour or 2 hours, depending on the resident's needs, to verify the resident is safe. But every time a door is opened, the light shines in, the floorboards creak, and there is a very real risk that you wake up the resident as well. And on top of that, this is a startling fact that I came across. About 70% of the residents in care settings today, elderly care settings, live with cognitive impairment or dementia, meaning traditional call buttons often go unused when help is needed the most. Raj, from an operational and resident care perspective, how does your team navigate this delicate balance between ensuring safety and protecting peaceful sleep? Perhaps you can elaborate a bit more about the challenge.
Yeah, I think what we've had, we had hourly checks on pretty much all our residents, and that has been pretty much a sort of practice that everybody had followed because they'd always done it. What we found was that when we had falls, they were inevitably, literally, as somebody had closed the door for their hourly check, woken somebody up, and they'd perhaps fallen in that hour. And because they were on the floor, or they'd somehow not triggered the pressure mat, or the pressure mat wasn't switched on, they couldn't reach the call bell, and they were there perhaps for another hour or so. And that to us was the biggest concern, that people were falling and in discomfort for that period until they were checked again. So that was a solution that we couldn't sort of overcome, really. We put pressure mats in place, but again, as I said, pressure mats, sometimes they work, most of the time they work, but sometimes residents fall over them or step over them knowing that it's an obstacle, and it just didn't seem to cut it every time. So it's that hour that we had, and some people would, in cases there were 2 hourly checks. So if people didn't, if people fell literally as they were woken up, it could be 2 hours before they were discovered.
Yeah, and what was the impact once the fall had happened? You talked about occupancy risks. You talked about the administrative burden once the incident does happen. Maybe you can talk through what happens next in the event of fall here as well.
Yeah, so again, as we know, if somebody falls, you first check them over. We have to call for medical assistance. We're not nursing homes, so we don't have nurses on site. You can't necessarily move them. You have to get medical intervention, which means that typically at night in a smaller home, if you've only got 2 staff on, then effectively one member of staff is then taken up with that one resident, and then another member of staff has to be called in. So now you've got 3 people on at night, so you're increasing your night shift cost, if you like, by 1/3. But also, somebody's sitting there with them waiting for the paramedics to come out to check them over before you can move them. So then, not to mention the paperwork that goes with that, filling out the reports, filling out the paperwork, getting all the care plans sorted out, and if they have to go, and then if they have to go to hospital, again, that's a separate thing. Member of staff has to go with them. That could be, you could be waiting hours for an ambulance, and at one point, a few years ago, I think we waited over 24 hours for an ambulance to come out. So you can imagine the sort of discomfort that resident has to go through, but also having a member of staff sitting with them, making sure they're okay for 24 hours is quite a trauma for that resident. And if you can't move them and you can't lift their head up, then their ability to drink and eat during that period is also restrained, and the consequences of that can be quite dramatic as well. So the knock-on effect of one single fall, you just can't measure it in terms of cost, because it just so depends on the circumstances at the time. But the the impact on the staffing and the documentation and the timescales and the quality of care that's provided to that resident during that time, it's at risk.
Thanks, Raj. And one question for you, Karen. So we talked about the impact on the operational side, but from a clinical perspective, we're talking about sleep as well. So how does broken sleep affect the residents' well-being the very next day? We've got some very nice, interesting to share with the group here a little later on, but maybe sharing your clinical perspective on that would be useful as well before we get into it.
Yeah, sure, of course. So if you think of yourself, if you have a disturbed sleep, so if that sleep pattern is broken for yourself in the morning, you can imagine how you feel. You don't feel your best. Well, if you put sort of maybe 50, 60 years on with a resident whose our average age is around probably 88 to 85-ish, even older than that. So if they have a broken sleep and they're not going to be performing at their best the next day physically or mentally. So we have found that there's an increase in falls potentially during that particular day if they've had a disturbed sleep, which again is something that we want to prevent at all costs, really, because even, you know, as Raj alludes to, the effort that you have to put into that situation when somebody has a fall is so stressful for that person, and the cost impact as well. So if somebody does have a restful night, it's far better clinically for that resident the rest of that day, the following day.
Thank you so much for that, Karen. So with that said, I think that brings us straight into what we do. So we talk about acoustic monitoring. At Earzz, what we want to do is to empower care teams with non-intrusive, intelligent acoustic monitoring insights, with the sole motto of trying to aid fall prevention and enable proactive care as well. And how the system works in practice, I'll be fairly brief on the tech side. We can obviously take questions a little later. But what we have is a little sensor pod. Like, as you can see in my video, it's a little pod the size of a golf ball. And it's a system that's designed to listen for specific sounds of concerns, not any noise. It actually understands, delineates, and recognizes specific sounds, like sounds of shouting, screaming, coughing, the resident beginning to move out of bed. And once these sounds are heard, the alerts are sent straight into the carer's existing mobile handsets. It can be a PCS device, a care vision device. And there is no listening on the other side. They're not then listening to sounds. The system has done the listening for them. And it then sends the alert straight to the carer's handset so they can proactively intervene. And from the time the sound is heard to when the alert is sent, it's just a matter of seconds. And this helps proactive intervention, but besides the interventions, the system also uses the sounds that it has recognized in the room to understand what the patterns of behavior are for each resident individually. And this goes back to what Karen was saying as to understanding the baseline of sleep. And if there is a change or restlessness during the night hours, that's something that the system automatically analyzes, uncovers, and sends behavioral anomaly reports for as well the very next morning. So the management team can use that insight for proactive interventions as well. And we do all of this by recognizing sounds, not speech, and we also do not store the raw audio. So we want to engineer the privacy protection into the system as well. With that said, let's look at the actual numbers now when it comes to impact. Raj, could you perhaps walk us through the one-year audit that we are having in front of us at Terrington Lodge? Maybe talk a little more about the home. We deployed the solution in May, I think, last year, and since then we've seen some fantastic impact numbers. So maybe you can talk to them.
Sure. So Terrington Lodge is one of our smaller homes. Got 25 residents. On average, we were experiencing about sort of 13 falls in a month, and that wasn't untypical, one every other day. And what we found with Earzz, as soon as we put it in and our carers were alerted of a movement in the room, we knew that that person was up. We were actually able to go very quickly. So combining that with the care plans, I guess, if you know that John in room 6 is more prone to falls and he's now awake and your phone has alerted you that John is awake, you prioritise John to get to his room far quicker than you might do Mary, who you know that can go to the toilet on her own and get back into bed and has no issues. And again, what we saw was, as we started to prioritise those residents that were more at risk, the number of falls during that time actually began to fall quite dramatically. So April, it was 13, as you can see. May, we reduced that by almost a third, back down to 9. And then again, in the following month, that was down to 7. And after about 3 or 4 months, once that system began to be embedded into the way that staff worked and the way that they understood that who was a priority and who wasn't, because our traditional call bell system said, room 1 rang first, so attend to them, and then it would almost be on an oldest first sort of basis. And it was changed. We ran that system together along with Earzz. So there was this sort of conflict almost, was, do we follow the call bell system or do we follow Earzz? And we said, no, now we're going to change it. So we will follow the Earzz priority first. And when we started doing that after 3 months, you can see that literally from between June and July, we got down to almost 2 falls. And back in August, well, there weren't any falls at all. So now we've sort of better understood how it works. And if you look, we've sort of been tapering on about 0, 1, 2, that sort of level. I think it's made a tremendous difference, but it's been, I think the biggest thing is changing the mindset of how staff work. We haven't quite got around to switching our call bell system off at night, but the hope is that actually very near future, we will actually just turn our call bell system off and rely solely on the Earzz alerts rather than the call bells.
So on that point, you were talking about the transition here, right? So one key learning for us as well, as we started working very closely with the team at Terrington, was the need for personalization of the alerts. So you talked about prioritization, but what was interesting was they began seeing, especially the dementia cohort, we were seeing a lot of people vocalize at night, perhaps due to some downing going on. But the vocalization, because the system was alerting for those specific sounds of vocalization, even before they got off the bed. So you're not talking about those people who are moving out of bed, but people who are beginning to call for help or shout. When those sounds were heard, it was very useful for the carers to intervene. And that first off helped the first sort of drop in falls that you were seeing there. And then we also began rolling out the behavioral patterning element, right? Anytime there's a change in restlessness, the system was picking that up. And that could help uncover the root cause for the restlessness as well, because we were looking at shouting and coughing and why the person wasn't sleeping at night, which transformed the game. And that's sort of when we started seeing these massive drops. And then people started adopting, the carers started trusting the system a bit more as well. And that truly changed practice in a way that was fantastic. And that's sort of when you built a lot of confidence in the system as well, when you were seeing these numbers and you were hearing the feedback from the carers too. Maybe you can comment a bit more on that side as well.
Yeah, I think a lot of it's about change management. We've always done it this way. We've had this nurse call system for 20 odd years, and that's what we follow. And this isn't reliable. And we've gone in there, and someone's been asleep, and so it was building the system and gaining its confidence, and also tweaking it in the early days as well. I think there was a lot of tweaking involved, because there might be somebody that just shuffled or turned, and then you had to adjust the sensitivity of the system. But I think now it's actually become part and parcel and embedded in their working routine. I'm not quite sure how they'd actually manage without it in that particular home. Now that it's been running there for over a year, I think all the new staff that have come in, it's part and parcel of what they do. So getting that change in any new environment, any change in routine, any change in process, all takes a lot of time to embed in the staff, and it takes the staff time to get used to it and build their reliance on it, and actually begin to trust it and understand how the system works and why we use it. And when you sit with the staff and show them these figures, they can't believe that we had 13 falls in a month in the first place. Did we have that many? I said, well, yeah, that's basically what it used to be. These are live figures. So now it's yes, very much embedded in that home. And we're rolling it out slowly, home by home. And the other homes now that haven't got it actually want it. and because they're seeing the differences, and we're seeing in some homes where we're still having the falls, and in homes like Terrington where they're literally at sort of that zero level.
Very good. Thank you so much, Raj. With that said, let's maybe hop on to Heathlands Village. Karen, perhaps you could share a bit more context to the home as well, and maybe then jump into the impact. I know we are early in the process here. We're just 3 months into the journey, but it'd be great to hear your feedback so far, understand a bit more about the home for the audience as well, and then maybe talk to some of the insights we've been getting from the system.
Yeah, sure. So we are based in a 5-acre setting, so we do have potential for 200 beds, but we're currently only operational at the minute for 97 beds. We're just reconfiguring the site and doing some extra building work and design. So with 97 beds functional, we've got 5 households of varying sizes, from 11 beds, 20 beds, 28 beds, 16 beds and 18 beds. So largest household that we have is 28 beds, and the smallest is 11. So like Raj said, we've only just been using the Earzz for like just coming into our 3rd month. A little bit of similar experience to what Raj explained at the beginning, that staff, it's change and they don't like new things, even though it is tech, because a lot of our younger staff are into technology. So it has taken a little bit of settling in with the teams. We found that staff have muted their handsets on some occasions. So we're working through all these different scenarios that are presenting. But now that staff are getting used to it, as you can see from the slides, the bedroom falls are decreasing. We've done extra sort of training with teams actually on the floor, so they don't have to leave to come to the training room. We've taken the computers, we've gone through everything, we've listened to what their feedback is. But again, it is the big change. There's still, if we do have a fall, the first thing is the sensor map didn't go off, and the thing that we're trying to get them to think, never mind the sensor map, what about Earzz? What happened with your Earzz? So we're just working through that. We haven't removed all our sensor equipment yet, but we're close to phasing that out in maybe the smaller unit first, second unit, and so on, just to get staff more focused on the Earzz technology. But even from the graphs, as you can see, our baseline, the first one, has dropped from 15 falls down to just 6, so that's more than half. And the same again, dropping even further into our month 3. So staff are getting used to it. We are seeing the results. And what I find very useful is the information behind the Earzz. So you can delve deeply into the system to look at if there was movement, how many movements, how many staff responded. So the back information is absolutely superb. It's brilliant. It gives you lots of information.
And I think we've got a couple of slides on that, which we'll come back to, just to show the audience what that information even looks like and how we put that into practice. I've got a couple of rooms we can jump into and give some real world data for. And we definitely look at that. And also the coughing trends. That's another point which we'll come to a little later. With that said, Raj, I'm jumping back to you here. So we talked about Terrington launch, and you saw the results in Terrington, and then we had a conversation about deploying it across the portfolio, starting with Docking and Driftwood. And it's been a great run at Docking House. We just had 1 bedroom nightfall in the last 6 months, which is a phenomenal record for Docking. So again, Sherry and the team there have been fantastic. So keen to hear your thoughts on what prompted that move, and then also talk about the applicability of the impact. So what that process looked like for you to ensure that we ended up in this space that we are in today.
Yeah. So as we said, Terrington was a sort of trial for all of us, really. And there was a lot of learning and a lot of understanding of how the system works, a lot of tweaking of the system to get it right. And I think Brad and his team have been sort of absolutely amazing at picking up some of our, well, not some, all of our feedback and putting it back into the system so that it learned more and more, and it just got better and better. And so we've got 6 homes, and we wanted to sort of roll it out home by home. Docking House was the second home. We've got just under 40 residents there, and again, we had exactly the same sort of teething issues about staff not wanting to change the way they work, being very reluctant. Docking House is a home where the call bells were literally going 24 hours, and you had to look at the monitor to see who was next on the call list. And that's, again, just the way that it operated. And when you've got both systems operating in parallel, it's very difficult for the staff, because they're looking at the call bells thinking, why is that going off? Which room's going off? But Earzz might be saying something slightly different because the priority there is a different room. And again, it's about the staff now actually having to think about who is a priority. And it also means that they have to understand the care plans a bit better as well, because it's not just a question of coming in and saying, right, who's next, and following a process. It's about understanding their residents and understanding their care plans and prioritising their workload and having to make decisions. And again, same sort of scenario, really. We saw falls sort of drop. And again, recently we've gone through a couple of months where we've had 0 falls. And now what we've begun to do is compare the data between the various homes, and we share the data as well. And again, we've gone into, I think, a 3rd and 4th home, and now there's this competition that this home's average at attending a call is 2 minutes 30 seconds. We need to get ours down to 2 minutes 20, and actually what it's had is a natural effect in the response time has been much better, and it's improved. It went down from nearly sort of 8 or 9 minutes down to sort of 3 or 4 minutes in literally within weeks. So we've seen some major improvements, not just in the number of falls, but also the response time as well.
I think you hit a couple of points there, which I think would be useful to elaborate a bit more. So you talked about prioritization, number one, how the system is helping the prioritization journey. You mentioned the care plan correlations. That was one other point that you touched upon. So I think it's, and also you mentioned the time taken, the response times. So it'd be useful to just talk a little more about the solution. So it's clear how the system actually catalogs all of these things. So when it comes to prioritization, you will see in the next few slides, this is more for the audience, you will see in the next few slides that the system doesn't just alert, it actually documents what the baseline patterns of behavior are in each of the rooms. And when that changes, going back to what Karen was talking about earlier, the correlation between sleep and fall risks are something we see time and time again. So when there is restless nights, when the system observes more activity in one of the rooms, it automatically analyzes that data, automatically points that data out as a report, and then it automatically triages and prioritizes alerts from that very room. And why is that useful? That means when a person hasn't slept very well, as Karen just mentioned, the chances of the risks of incident increase the very next day. So there is a need to prioritize, and that is why the system automatically does that. And that, we think, that is sort of a very important point in the monitoring process, because if once the door is shut, you obviously don't have, the carers may not have visibility to what happens inside the bedroom at night. Having a system like this gives you that visibility, and using that visibility and plugging that into your care plan would be one key benefit to a system like this, which is sort of what we're doing with the likes of PCS and Care Vision. But besides that, we also do this anomaly alert, which has truly helped in many of these instances. That is something that you will see in the next slide at Heathlands as well, or the next few slides at Heathlands as well, of how that has helped transition the proactive care mindset. And second, when it comes to the system, it also digitizes room checks. So when you talk about response times, Raj, one other important aspect of the system is that anytime the carer goes into the room, they would simply tap the button, and that digitizes their room check, and it then calculates the time taken from the first alert to when the carer has actually gone in and pushed that button. So it gives hard evidence back to the management team. So you can actually see if certain rooms are being responded to, which rooms are not being responded to, how quickly, how slowly. And that makes it really valuable because then you could focus on areas where we could potentially improve as well. And that's sort of what you're referring to here, Raj.
Yeah, I think one of the things that we did certainly pick up on is that we now got a good understanding of what's happening at night. Clearly, when management can't be there all of the time, so you don't know what's happening at night, how quickly people are responding to things. But now we do. And also, what it did, we highlighted a couple of things to us where we've got some shifts where calls weren't being answered within sort of 7 or 8 minutes, whereas you've got other shifts where calls were being answered every 2 minutes, and suddenly you discovered a pattern that actually this group of people here on Mondays and Fridays that all seem to work together have a much slower response time. And you could literally go back and say, well, hold on a second. Yeah, you're letting the entire home down because your average response time is being raised by your shift. So what's happening in that shift? Why is it that you're taking 8 minutes to get there when everyone else is taking 2 minutes to get there? And when people realise that actually you can monitor all that and see that, suddenly the behaviour of staff changes. I mean, I remember early on we had some feedback and somebody said, this is the worst thing you've ever brought into the homes. And I said, oh, now to me that was brilliant because it now made me dig further into why they had this sort of thought that Earzz was the worst thing ever. And it was purely because suddenly we could feed back to them how long it was taking for them to do their job. And that sort of changed the whole mindset of the rest of the team. But now it seems to be healthy competition, which is what we're trying to drive.
And just going back to the ROI aspect, so we're talking about the monthly fall reductions, but typically when you think about fall reduction, the first thing that comes to your mind is that you may be doing more checks and therefore reducing the number of falls, which is actually the converse here, which is true. And because we're cataloging the room checks, you can see the reduction there as well, and the improvement in sleep as a direct result. So maybe you can talk about again, you mentioned the ROI aspects briefly at start, and in this specific home, you have the data. So I think
what we found was that if you've got a home where you've got, say, 3 staff on at night and everyone said, oh, we need more staff, we can't do it, we can't cope, we've got to do this, we've got to do that. And actually what you're doing is by reducing just even the number of night checks, because if you've got a 40-bed home, it literally takes somebody a minute and a half to go around every room and check whether someone's okay, whether they're wet, whether they're asleep, whether, whatever. It's time for that person to literally start doing their rounds again by the time they've documented it. So you found that one person was literally doing nothing but going around. And if you're now allowing people to sleep for, say, 4, 5, 6 hours because they're not waking and they don't need to be woken, then actually the number of checks literally diminish to a fraction of what they were before, which actually gives people far more time to do some of the other tasks. And what we've found is that, particularly in one home where they were constantly saying, we're short staffed, we need more staff, that pattern of desire of more staff suddenly stopped because they actually found it easier and it gave them more time to do other tasks. It gave them more time to document what they were doing and more time to spend with some of the residents that were awake and in the lounge during the night. So I think overall it's hard to sort of work out a sort of exact figure on what your return on investment is. But what I do know is that to put on an extra member of staff every night for 365 days a year is going to cost you about 70 grand a year. Now, I don't know what, everyone can do their own calculations, but to do 10 or 12 hours a night, 7 days a week, you're going to need 2.5 new extra members of staff. And if you count the cost of 2 extra members of staff, you're looking at about 60, 70 grand a year. So again, you just work out the fact that if you're on that cusp and you don't need those extra staff, then you're actually saving quite considerable money, but also you're making your staff's life a lot easier as well, because they're not rushing around, they're not doing checks, they're not doing the things that they don't have to do. And it does make for a far better shift and less burnout amongst the staff as well, especially if they're doing 12 hours. It's quite a long shift, or 10, 12 hours. It's a long period of time.
Thank you, Raj. And now jumping back into Heathlands Village. So this is what I was talking about before when Karen mentioned the data behind the system was quite valuable. So I pulled in one of the rooms here to show you what the profile is at nighttime. And what is interesting here, just to get the audience up to speed, what you're looking at is the instances of coughing at nighttime in this specific room. And you can see the person has a baseline level of coughing, but when there's a change, when there's a sudden shift in restlessness, the system automatically uncovers that, and it starts flagging these little comment boxes that you see are the behavioral anomalies that the system has uncovered. But what was very interesting when Karen and I looked at this was the correlation that sleep pattern had to fall risks. And you could see as the person got really restless at night and they're coughing a lot more, there's an immediate fall event that follows the very next day. So this is where we got a lot more understanding of what is triggering the restlessness. How can that be correlated? This is the exact clinical point that Karen was talking about right at the start. And this is showing it in action, right? So you're actually seeing the correlation between nighttime restlessness and fall risk play out in this specific case. And you can see how well correlated those two are in this specific case. But having said that, we've seen this pattern emerge time and time again. And you mentioned other aspects as well of the behavioral patterning element here, Karen. So maybe you can elaborate on what value you see with something like this in a clinical setting.
Yeah, so obviously seeing the restlessness and increased coughing, what we find extremely useful from my nurses who've said already, it's great that you get these clinical insights into a person that you wouldn't normally know about. I mean, once the door's closed, you're not stood outside all night listening to a person. But the fact that this system picks up not only the restlessness at night, it picks up coughing. So if somebody's got increased coughing, the system will show it. And we recently, excuse me, we recently tracked an outbreak on one of our households.
I've got it here, Karen, so you can see the progression.
Which this was on our small household, which is 16 beds. It's quite the residents are very sociable. They like to get together often. They like to eat the meals together. They're not really residents who want to stay in their room. Even if you ask them to stay in their room, they like to come out and socialize. So this is what happened, and we could see over the period of nights, one room that had raised coughing. We had the GP out, antibiotics that may have been prescribed, and then it sort of followed a pattern where they'd socialized and the person in the room next door to them developed increased coughing and so on. So we were able to track very easily on the system that pattern of who's starting coughing. It gives us more clinical insight and better decision making for a GP, for us to be able to call them and to say, this is what we've evidenced here, which normally you wouldn't know because you wouldn't be listening outside that room all night, so you wouldn't know. You'd be reliant on that resident, how the presentation was, and could they tell you that they've been up all night coughing. So we find that part a bit invaluable as well.
Very good. Thank you so much, Karen. And just to summarize, we've been talking about the system. We talked about infection spreads and how the system has helped provide some intelligence there as well. But in a nutshell, what we are referring to here is an acoustic monitoring capability. But we focus at Earzz, we tend to focus a lot on specific sounds of concern, then pattern behaviors based upon that to get a baseline to help inform proactive decisions. And that could be sleep disruptions, that could be also giving you the records, right? So room check records and what the baseline looks like what you've just seen there. And that truly helps with governance records as well. And this is something that we are integrating with care management software solutions like PCS and Care Vision. I think you use Care Vision yourself, Karen, so you can see some of that data come through there. So you have been talking about staff acceptance. That's been a theme through the entire conversation here. So I had one slide here to just talk again a bit briefly about the sequence of events that you've followed operationally to build the staff buy-in here as well. Maybe Karen, you can start off, and Raj, you can complement.
Yeah, sure. So as I say, we've only been using the system 3 months, so we've literally just today done a review of every bedroom, because in the initial setup we were quite cautious on, well, who stays in the bedroom all day. We need to have that on 24 hours monitoring, and so the carers were on some areas, were getting quite a lot of movement alerts, and I think they were getting a little bit resistive, should I say, to the technology. So we have done a full review today of every room on site, every resident. So we've changed down now to about, on one area where we had maybe 8 rooms that were on 24-hour monitoring, where people are staying in the rooms, we've been able to reduce that down to about 3, because we've reviewed again the falls risk. So, and the system gets used to that person in the room as well, their habits and everything. So we've just recently just done all that today, reviewed it, which has been sent through to Guy at Earzz. So it's just reviewing everything as we go along and making it less, not onerous is probably the wrong word, but there was a little bit of fatigue with staff at the beginning, because they were getting all these alerts coming through, and they may have been donned in PPE. One of the things was, well, you know, how can we keep just taking our gloves off all the time to check, you know, 3-4 alerts in one go? So we're going through the process of, like Raj said, prioritizing the very high risk people of falls. So if you know that room 9 is showing the movement, you know, right, you stay here, I'm going. So they're getting more used to that mindset now, and of course with the review and everything, that will get even better. So yeah, it's just the change management.
And you also mentioned 2 things. That one was about the prioritization, and it's worth just mentioning that the system can be tweaked and personalized to get the alerts triaged for certain rooms in a different way than certain others, based on the behaviors they've had the nights before, but also manually. If you know the person is persistently with very high fall risk, you can also triage the alerts nonetheless. So that's something that we're able to do as well. And maybe Raj, you can say a couple of lines on this, and then we.
Sure. I think had a discussion with Karen the other day, and I had a bit of a smile on my face, because everything that Karen had said we'd already been through, and we'd experienced exactly the same things. It's all about managing change. You know, staff don't like change. They don't like anything new. Some staff are resistive, as Karen said, to new technology, different ways of doing things. You've got staff that have been there for years and always done it this way. Then you've got new staff that want to embrace technology, and you know, so everybody works differently. I think one of the lessons that we learned from this is that when we're introducing it into a new home, we give staff a little bit of a rundown on what it's about, how it's working, what it does, where we are at the moment, what we're hoping to achieve, and show them some of the results of some of the other homes. And you get the staff sort of buy-in, and what we've done is in each home we've got what we call an Earzz champion that sort of spends more time looking at the data, working with the staff, understanding what's happening in the other homes. So there's a lot of learning by the staff to do in terms of accepting the system and then adapting to that change. And when it clicks, it suddenly happens, and suddenly everybody's on board, and that's basically what you want. Like with any new technology that you introduce, whether you go from written care plans to you know, typed care plans or whatever, you know, it's always a big change for people, and people don't like it, and they are resistive to change. And I think this is something that everyone's seen it for the betterment of for the residents and the quality of service that we provide, and also giving them a bit more free time, particularly at night as well. And I think that's also been the biggest selling point. So yeah, sell the positives, get people engaged before you start it, during the implementation, and also afterwards, and maybe have somebody on the care floor that's actually sort of championing it and looking at the data and feeding that back. I think that all helps to in the transition of introducing something new.
Sounds brilliant. Thank you so much, Raj. With that, this is the last slide we have. It's just running through the key results again from each of the roles we've just discussed. But I was hoping we could just leave it stay on the screen this way and maybe start taking some questions. Is that okay, Karen and Raj?
Yeah,
There
sure.
are quite a few in the chat, so we can go through all of the questions here. I see Richard has, what period of time did you trial the Earzz system before implementing, and was this across all resident rooms? I can give a year's perspective to this, Colin. This is from Colin English. Thank you for the question, Colin. So I was thinking I can give the year's perspective, and then we can talk through how we transitioned from Terrington to docking as well. So Terrington was the first home we introduced the system to, Raj. In this case, yes, it was in all of the resident bedrooms. And we ended up, the reason for that, from a year's perspective, we tend to go with that purely because you don't know what the change in needs will be for one resident the very next month. So having the system pattern that and help you guide that decision by giving you some intelligence will also be very valuable. And besides that, you're looking at consistent trends, you're looking at operational practice change as well across your entire home. So having it in just a handful of rooms doesn't do it. And it's not just about falls, it's trying to give you the insights on what happens in each of the rooms once the door is shut. And that applies for pretty much all of the residents, not just a handful. So it's something that we would definitely recommend going for all of the resident rooms. That's what we work off, and we've seen the best results every time we deploy the solution across the entire home. And that's become part of the policies in the company as well for us. But for Raj, I think we did Terrington Lodge first, and then Docking House followed in about 3 months after Terrington. Is that right, Raj?
Yeah. So Docking House, and then I think we did Driftwood, and then Whitehaven, and I think
Correct.
we're in the process of installing in Norfolk Lodge as well.
Lodge, yeah, Norfolk Lodge is next week.
Everybody's looking forward to it, and the last home, unfortunately, we're still experiencing some falls, and now they're desperate to get their hands on the system as well, because they don't want to be the only home that's having falls. But I think once people see the benefits of it, it's just a win-win for everybody. And I think more from any other perspective, the quality of service that we provide to our residents and their families, when they see that the technology that you've got is actually minimizing the risk factor of their loved one falling, it's tremendous. It's exceptionally powerful, particularly if you're trying to attract self-funding residents. You can then really home in on some of this new stuff that you're doing, new technology. We're all being told to work smarter, look at new things, look at new ways of working, and this is certainly one of them. And the journey that we've been on, probably over 18 months now, Brad, I think. Mm-hmm. Possibly even longer. It's been tremendous, and we wouldn't have it any other way, really.
And just on that very point you mentioned there, so I remember there was a resident in Driftwood House who was saying she would often shout, but the response wasn't there. And then this was specifically, we installed it across Driftwood, but then we wrote a little document for the family members as well, that person. That's a very nice case study. Maybe you can say a couple of words on it.
Yeah. The family actually were very concerned about their mother shouting and screaming. She was in her room most of the time, and like always, she didn't always press the bell, but you could sometimes hear her. But it was sort of a constant sort of battle to keep her occupied and to make sure that she was okay. We then told them about Earzz, that we'd had it in the other homes and we were bringing it into Driftwood, and I think Brad did a little write-up. We gave it to the family. They were going, wow, this is amazing. When can we get it? And as soon as we installed it, actually, the attendance record for that room, her shouting and screaming actually went down because she was attended to a lot quicker. She was less frustrated, more able to communicate what she needed quicker, and therefore, the family were happy, the resident was happy, the staff were happy, not having to listen to her shouting and screaming all the time. So,
and we also did a quantified evidence base as well. Sorry to interrupt. We were talking about where we started, and then we were showing vocalization trends in the room drop, which was a very powerful sort of case to even for the family members, right? They're seeing.
Yeah, absolutely. As Karen said earlier, the data behind not just the alerts and the calls is so powerful. It's powerful in that if you work with local authorities and you're trying to get from a standard rate to an enhanced rate, and they say, well, why? You can then show them the data. Well, actually, look, this person wakes up 12 times a night and is shouting, screaming, coughing, whatever, and they need that additional level of care. And that's something that we wouldn't have that evidence otherwise. And now we've got that evidence. We've been able to actually sort of transition many of our residents from a standard care package to an enhanced care package, which, £100 odd a week it's not to be sniffed at, really.
Great, thank you so much. Let's move on. Alan Perry, thank you for the question, Alan. Given you're talking about whether this can detect respiratory sounds as well. Am I right in saying that? Detect breathing. So we don't detect breathing per se, but we do detect coughing sounds. That's something that we detect. Any movement, restlessness, and the movement can be based upon the resident's needs. So there are some residents who are, let's say, end of life or bedbound, where even the slightest movements in bed is something that you would want to get alerts for. So we customize all of those things. And this is exactly what Karen was talking about right at the start as well, where some of these sensitivities were quite high and they were alerting for even movements in bed. So we control that. We can now calibrate that. The system does the calibrations automatically as well. But to answer your question directly, we don't detect breathing, but we rather detect sounds of coughing or even movement, and then use those to pattern behavioral changes as well. Richard, in the interim period when you have the call bell, sorry, Richard.
I'm conscious we're very close to calling time, so if we can do some kind of quick responses, that'd be great.
Okay, cool. Let me just sift through the questions then. You had, when you have call bell and the alerts to respond to, how do staff decide what to prioritize? So the system has, as I was talking about restlessness there, the system catalogs and catalogs the change in behavior automatically. So it knows when the what the resident's usual behavior is, and then if you had marked them down as a person of high risk of falls, when that changes, when the behavior changes, it knows, and it then starts prioritizing that. It's the alert sounds different. It sounds like a siren in the phone. It triages itself as well. So that's something that system does. But if there is a change in resident, or if there is a need to manually intervene and prioritize, that's something you can do in the system as well. So you're able to set the priorities based on the specific needs of residents there. But besides you setting it, the system also does that automatically on its end if you want it to. So that's something the system is designed to do. I would also use caution in suggesting can replace call bell. I absolutely agree, Alan. And there is one side to the conversation here, which is if the person does not have the mental capacity to push a button, then it can truly serve as a very nice complementary tech alongside your existing call bell ecosystems as well. And so that's something that we need to consider here. Has CQC given any feedback? There was a home where CQC had gone and done an inspection. They had in fact commented about the system helping reduce the falls in the homes, Richard, so I can share that link to the audience a bit later with me. Average cost per resident per room. This number often comes up, and it's obviously a question everybody wants an answer to, but because every care home is different, every size and care software setup is different, quotes are often tailored to the site. But as a baseline, our acoustic monitoring package starts from under £1 per day per room, which includes the hardware, app access for multiple carers, behavioral analytics, management dashboard access, a lot of what you've seen, all included. So you don't have to pay extra for the hardware alone, as an example. When you weigh that against the cost of the fall and all of the ROI elements that Raj has talked about, it could be a very nice. In fact, we talked about the dependency side as well, which is a very nice angle. So all of that is where the ROI really kicks in. And maybe Raj, you want to finish this up with a quick statement on the ROI.
Yeah, do you know, I don't. I've looked at many systems over the years, and some, you know, involve like thousands of pounds, and as I said, £1 a week for preventing a fall. It just seems like a drop in the ocean. Really, it's just nothing at all. Just to the cost of somebody falling, your loved one falling, breaking a hip, ending up in hospital. The cost to the NHS, the health services. In fact, if anything, we should be campaigning the health services to be funding us to put in systems like this, if anything. So I think the quality of service alone is well worth it. What you can sort of say to families that we've got these additional systems that other homes don't necessarily have, and this is what you're paying for as part of your fee.
So this is the last question.
Yeah,
sorry, Richard, one more question.
1 more minute.
Is that okay?
Okay.
Okay. Last question from Monica. Who will have access to changing the sensitivity of the device? So you have different tiers of control here, Monica. So you've got the primary users, and then you've got the super admins, and then you've got the secondary users. Think of primary users as the management team. So the likes of managers, directors, they will have access to changing the sensitivity. That's only done through the app. Carers will not have access to change the sensitivity of the devices. The carers will. That's the secondary layer of control. You would simply get the pings, the notifications. They'll be able to give feedback through the app, but they will not be able to change the settings of the device in the app. And in terms of behavioral patterns and things like that, again, those are reports that are sent to the management team directly. And there's also another layer of control, which is facilities. So in bigger care homes groups, you would have facilities team members who may want access to change in, if the system goes offline because of a Wi-Fi problem, they want to know first. So that's something that the system automatically fires alerts for as well. With that, I'll close questions. Over to you, Richard.
Brilliant. Thank you very much, Brad, Raj and Karen, and thank you to everyone who's joined today, contributed to the questions. I think the discussions reinforce that overnight monitoring it's not about replacing people with technology. It's about giving kind of care teams more information so they can respond more promptly, protect sleep, reduce avoidable harm, and support each other. And support residents' dignity and individual choice. So, we've also heard that technology alone is not successfully implemented without the staff behind it. So we need the right training, the right appropriate alert mechanisms, make sure the settings are correct, clear governance in place, and human judgment. We're not anywhere suggesting that there's anything that overtakes human judgment, which it's about how we inform that. The recording and slides, as I said, will be shared with everyone who registered for the webinar after the session. We want to thank you all again for joining us. Thank you for staying throughout to the end. And we want to thank our speakers and for everybody sharing so openly. So huge thank you, and we'll see you again soon. The videos and everything will be available to you before the end of the week. Thank you
very much.
Thank you.
Thanks, Richard.
Thank you, Karen. Thank you, Raj. Thanks, Richard.
Thank you.